Kathy Bouvier from the Net Patient Foundation.
Okay, so I'm Kathy. The Net Patient Foundation is the organisation that I work with. These are just slides for the whole of the UK. We have a slightly complicated treatment system as of 2015. Prior to 2015, we had access to all therapies across the UK, and except for CERT, which was only available in a small proportion of hospitals, but that has slightly changed. We have access to all of the treatments now except for CERT, but we do not have any funding in order to be able to give the treatments. So it's slightly complicated because we have to break the UK up into the four sort of devolved nations. So at the moment, PRRT has just been removed from our commissioning from our Cancer Drugs Fund in England, so no patient in England can access that as a therapy. We're currently obviously fighting this with our authorities, but if you live in Wales, Scotland or Northern Ireland, those three governments have all supported the use of PRRT, but they don't actually have them within the countries at the moment, so all those people can fly or come into England to gain treatment out of the centres of excellence, of which we have 10 in England. You can pay for it privately, but obviously at around £18,000 per dose. It's not something that we advocate. We do have gallium dotatate in some of the centres of excellence. We have octreotide and lanreotide that's fully funded. CERT, no, we are really struggling with being able to get CERT. We did have everolimus, and that's also now been removed from our government for funding for neuroendocrine tumours, and we're currently in the process of trying to get that back into our systems, but it's a bit of a struggle, and we still have sunitinib. So who we are? Well, I think we do the same as many of you do here. We provide a supportive service with our specialist nurses. We hold patient education meetings. We have discussion forums, information and crisis cards, and we have NATA support groups. We have 30 across the UK, and we also have a research arm too. With that research side of the organisation was started in 2013, and since then we have funded 5 research projects, and we focus only on pilot studies. So any of the money that we provide towards projects have to be for the total project. We don't support adding money into very big projects. So if there's a £3 million project, we won't give our measly 30,000 towards that. So they're all private, they're all pilot projects, and with the hope that there will be some success in that to then move forward into larger projects. We also do some of the European projects that we're involved with. We've just set up looking at quality of life. At the moment we have the EORTC Net 21 quality of life questionnaire. And of course this is quite a generalised GI net questionnaire, and we've just started a European project. Well, actually that's a lie, it's about 2 years old, looking to try and stratify quality of life questionnaires to be disease specific. So we will have a quality of life questionnaire for those with a FAO, for those with a lung net, for those with a pancreatic net, so that they're really specific to the patient, because I think asking quality of life questions for people with functioning or non-functioning disease all as one is not really very acceptable. And we also have supported the large immunotherapy pilot work that I think then went forward and got some funding from you, but it was great to be able to do the pilot study first so that we knew we had some answers. In terms of outreach and advocacy, again, I think it's quite similar to a lot of you. We provide patient materials free of charge to over 300 hospitals in the UK. We provide patient videos. We have a video channel called Net TV, and we update new videos for patient education on there. We have a patient forum and Twitter and Facebook feeds. We have this NATA initiatives, as I said. We try and get involved in raising the profile of advocacy by submitting abstracts to various European conferences and going to present there just to try and raise the profile for everybody working in the neuroendocrine tumour field. I'm involved, just as my background as a specialist nurse, within the ENETS nursing group, as also the UK nursing group. And we hold about 4 patient educational events every year. And, you know, on and on and on, really. We do various audits. We have been working really, really hard on probably our biggest issue, which I think somebody else has talked about, which is about the coding of neuroendocrine tumours. So as of the end of last year, we have now recoded all of neuroendocrine tumours with the help of Public Health England. We've moved away from ICD codes, and we now use ICO codes. So we've gone under an oncology umbrella, which means that we can really start putting our patients under the right titles. And that's been a really important project for us, and we have funded that project, which cost us around £75,000 because it wasn't being done by the government. But what it has meant is that even just going in now to look at our incidence of neuroendocrine tumour patients since 2008, going in with these new codes, we've seen a doubling of incidents, which is as we all expect, but at least we've got the factual data, to just under 5,000 new patients per year in England alone. So at the moment we don't have all of the data across the whole of the UK, but we have just placed the first ever cancer analyst with Inside Public Health England, and we are funding a 6-month post for that in order to be able to gain the data across the whole of the UK. So that data will be published by the end of the year. But one of the main focuses of the last couple of years, as I said, has been more about strategy, more about trying to lift neuroendocrine tumours into the oncology arena, because we've very much been forgotten. And we only performed our major patient experience survey, which we commissioned because every year in the UK there is a patient experience survey for all cancer patients. And when we went to interrogate that data, there was only 7 neuroendocrine patients that were included in a survey that covered 250,000 cancer patients. So obviously neuroendocrine tumours were being pushed aside, but we kind of knew this. So we did commission our own patient experience survey, and I think over the last couple of years we've presented that at various conferences. But the main piece of work that we're just in the middle of now is trying to raise awareness of some of these uncommon diseases within our cancer strategies, because we really feel that we've got to try and get these diseases recognised within major government strategies, or we're just not going to get any funding for anything in the future. So we produced a report that went out on Net Cancer Day, and I did share it with the community, and INCA supported that, as did ENETS and UKNETS. And really just trying to make some recommendations. I think I mentioned earlier that there were 96 recommendations for improving our cancer healthcare system in the UK, and only 2 of those were related to rarer or uncommon cancers, so it was very much forgotten. And we're now just continuing that work in Northern Ireland, Wales and Scotland, and all of those reports hopefully will be out at the end of the year. And I'm going to stop there, but this is just one thing that I know that we keep banging on about, but it has certainly been a mission of ours over the last 10 years to try and improve what I think is ultimately, and what I said yesterday in the symposium, the only way we're going to change anything is to improve our education. I think it counts for awareness, it accounts for advocacy, it accounts for everything, and I just believe, and I just wanted to share that I think that's the only way we're going to make any change. But I shall stop there. So we did one audit. We went to find out who did a lot of the work for the NHS. So obviously the NHS as our organisation, as our it's our health organisation, do a number of audits themselves. So what we thought we would do is try and work with the same groups that interrogate our NHS data, and ask them if they would commission or do some work on our behalf, because then we had direct comparisons with a lot of the data that they already had about various services within the NHS. And originally we wanted to find out how many people were looking after net patients, because I think so many of you said this already, that we know how many patients the net centres are seeing. We know now the incidence, and we have an idea of the prevalence, but they just simply don't match up. So there's however many patients being seen in the net centres, and then there's about, potentially 10, 12,000 patients that are being seen where. So we went and did an initial audit, and you have to get approvals through the NHS and government systems, because you have to access patient data. So it's quite a complex process, actually, and it took about 7 months just to set that up. But then we did telephone interviews, and we also did visits to, I think it was 350 hospitals. So it wasn't across the whole of the UK. And that was when we discovered how many people were actually looking after net patients, whether they were seeing 1 or 2 in their clinics, or whether they were seeing 50 or 100. So it was quite an eye-opener for us. Obviously, we also did the centres of excellence and the places that we knew, but there were just so many places that were seeing patients and obviously not referring them into specialist services. But part of that process is to provide statistical proof that I'm just not making it up when I go and talk to, government structures or strategies or commissioning bodies, saying, you've got to ensure that all patients get, expert care, and this is why, and that's actually happening. So
your hospitals are on global budgets, right?
Oh, what? Sorry.
The hospitals have a global budget from the government.
Well, a number of them are trust funded, so they have their own budgets and their own.
I'm just wondering, is there an incentive or a disincentive for these non-centres that are treating 50 or 150 patients to send them to centres?
There's no disincentive at the moment. What we're trying to do, or what has happened for every other disease type, is there's something called a service specification, and that's an agreement document between the commissioners within the NHS and the hospital trusts to see certain patients, and they will reimburse that. So we now have liver centres, so if there's various liver surgery that you want to have, then, if you're not one of those centres and you perform that liver surgery, you're not going to get paid. So we have produced, along with a number of the consultants in UKNETS, a service specification for neuroendocrine tumours, and they have rejected it and not implemented it now. We're on the 4th year, just saying, we'll look at it next year, we'll look at it next year, we'll look at it next year. But if we can get that actually in place, it would mean that if you see a neuroendocrine tumour patient, you won't get reimbursed for that if you're not a commissioned service.
And what was the justification besides money for cutting PRRT and everything?
It's a bit of a political hot potato for us, because we've been using PRRT off licence for a very long time. And their reasoning for taking it off was that it didn't have a licence. They pretended it wasn't money. But it's been used on our cancer drugs funds without that licence, and it still doesn't have one. So I think it was a bit of an embarrassment, because they'd seen that when they went to review, because the Cancer Drugs Fund had so many problems and it was overspent, I think potentially they saw that, oh my God, this hasn't even been licensed and we're funding this, we better get rid of it quickly.
Well, they also did a score sheet. It's a publicly available score sheet to which they scored, and they got minus points for having no randomized controlled trial data when they took it up. So it was a combination of not licensed, there was no RCT.
No, but you could appeal that. So on the appeal, we put in the data from the NETA trial, and also they didn't use a lot of the data from the NETA trial. They used data from other trials that had happened, so that wasn't even relevant. And the scoring system was something that nobody really understood, because it was very much about side effect profile, for which we never saw any of these side effect profiles. They were talking about the vast toxicity of this as a treatment. But since then, they have done some more work, and NICE, which is our National Institute of Clinical Excellence, who decides whether we can commission drugs or not, are reviewing this, and we'll know whether we can have it back by July.
Just one last question. Kathy, you know your presentation which you did in, it's now referred to, you had that survey up 100,000 patients.
Yeah.
Is that, have you got that available, like the results of that, have you got that on, is that published?
Yeah, it's all like the whole paper's on the website, so that's, that's just go in and get it from there.
I saw a slide in the last 2 days amongst the hundreds of slides that I've seen, and there was data that was published that didn't include people who were on the private healthcare system in the UK. And I can't remember what the data was, but so my question to you is, how does a private patient get onto the registry to be counted? Because I was diagnosed in a private hospital.
On the data registry, on our cancer registries?
Yeah.
Yeah. I mean, at the moment we don't know, and we don't really know how that private system works. I mean, it should work the same way in terms of a diagnosis. You just go straight through to a cancer registry. But they believe there's quite a bit of a flag in that. When you talk to Public Health England, they say this is something they're working on, but they've got a real backlog.
Yeah.
So a lot of the private hospitals are holding their own data, and it's about trying to access that data. But there are issues around whether they really want to release that data or not.
And the fact that I'm now NHS doesn't make any difference?
No.
Okay.
No, because you're when you had your first appointment with the NHS, that would have gone through onto the cancer registry. Is there any other questions?
One question. Under European legislation, aren't you allowed to do doctors or religious affair outside the country? Why is that not happening?
It does happen, well, it's something that's very new to us, and I have to be totally honest and say that there is still a little bit of access to PRRT that's happening for patients with the highest need, and that's been a slight negotiation that's happened with the pharmaceutical company. So we are, and that's only just happened in the last 6 months. So when it was getting to the point where we were thinking, what are we going to do? We're going to have to refer patients out of the country. We did get some support only in a few of the centres of excellence. Well, in fact, I think all of them, that's true. 10 centres of excellence were given a small budget to treat emergency patients, so those in utmost need. So I think that's what they've done initially, with the hope that we're going to get a good result in July and that this will all be over and we'll have the treatment back again. So I think there's quite a lot of fingers crossed. Don't think about that yet. I don't know. We're going to have to, we're going to have a completely new strategy. But
The only way to put leverage and pressure on them by sending patients is that it's not working anyway.
I mean, it was interesting actually when I went to the NICE meeting, and I was talking about the fact that it's only the English people who can't access the treatment, but it is available across the whole of the UK, and all these, the English government don't like the fact that the Scottish government said yes, or the Welsh government have said yes. So that did raise a few eyebrows. So I've just got to keep my fingers crossed that we've done enough lobbying, and the patients have done a huge amount of work too in writing to MPs and all sorts of stuff. So yeah, we'll let you know.